Okay, this is going to be a mini lecture on Apthtous stomatitis and Erythema multiforme.
Okay.
Working?
Whenever you're ready, go ahead.
Okay. Today we're going to talk a little bit about Apthtous stomatitis and Erythema multiforme, starting with recurrent Apthtous stomatitis. Now, of all the ulcerative conditions that we encounter in the oral cavity, next to traumatic ulcers, recurrent Apthtous ulcers are very, very common. What are some of the things we know about them? They're also called canker sores. The disease that characterized by Apthtous ulcers is recurrent Apthtous stomatitis. So that tells us something. I mentioned that they're common. They usually start sometime in childhood, probably by late adolescence, and most people cease to get them around age 50. Although many patients will say that their canker sores are precipitated by stress, many other precipitating factors, probably unique to every single individual, can be found in a history of someone who gets canker sores. Obviously, this is a recurrent problem, so usually the patient will have a history of prior episodes, and how often they occur is very variable from patient to patient. What are some of the features that we associate with Apthtous ulcers? First of all, they can appear as a single lesion, or there may be multiple lesions that are widely scattered throughout the oral mucosa. But among the most important features is their location. They occur almost exclusively on unkeratinized oral mucosal locations. However, patients do get canker sores on the top part of their tongue, the dorsal surface, and that is another area where Apthtous ulcers are not uncommon. How do they look? They're described as round or ovoid ulcerations. They have a yellow-white center, and they usually have a slightly raised erythematous halo-like border. Typically, Apthtous ulcers are small. They are less than 1 centimeter in diameter, although we see occasional ulcers that are larger than that. But regardless of size, these are very painful lesions. How do we classify Apthtous ulcers? Well, we classify them according to size. So the typical or classic minor Apthtous ulcer is an ulcer that is about 1 centimeter or less in diameter. Major Apthtous ulcers are defined as 1 centimeter or greater in diameter, whereas herpetiform Apthtous ulcers typically present as very tiny ulcerations, maybe 2 to 3 millimeters in diameter, and usually they are arranged in clusters. So let's take a look at a few of these Apthtous ulcers. Here are a couple of examples of so-called classic or typical minor Apthtous ulcers. And notice the location. Each of these ulcers is on unkeratinized lining oral mucosa. So the one we're seeing in the upper left-hand corner is an ulcer that is round with a yellow-white fibrinonecrotic center. It has an erythematous border, and notice that it does not go onto the attached gingiva, which is a highly keratinized oral location. The other one is on the soft palate, which is an unkeratinized oral location. Several other examples of recurrent Apthtous ulcers on typical locations, including the lower labial mucosa, the upper labial mucosa and frenum, and we have one on the lower labial mucosa in the lower right-hand corner. These are a couple of examples of major Aptthous ulcers. So these are the ones that are about 1 centimeter or greater in diameter. And notice that in the slide on the upper left-hand corner, we're seeing a large Aptthous ulcer adjacent to 2 smaller ones. This is not an uncommon presentation. We see the uvula almost dissected off by a very large Aptthous ulcer. And we also can see a couple of examples of Aptthous ulcers that are in very trauma-prone positions, such as the one on the lower left-hand corner, where it's no longer round, but it's been hammered by one of the teeth, and now it's kind of rectangular in its shape. So what are the major distinctions between major and minor Aptthous ulcers? Well, first of all, the size. And typically, the small ones will resolve within about a week or so time. However, the larger ones can take a bit longer, usually more than 2 weeks, and if they get traumatized, that can be a much more protracted course. And in some instances, a major aphthous ulcer can heal with scarring, but most of the time we don't encounter scarring in recurrent aphthous stomatitis. Now, I mentioned before that there is a form of aphthous ulcers that we refer to as herpetiform. Well, what does this mean actually? Herpetiform aphthei have no relationship whatsoever in any causative manner to herpes infection. However, the ulcerations, because they are very small and they're clustered together, really resemble the kinds of ulcerations that we see after vesicles of herpetic lesions have ruptured. So let's take a look at a few examples of herpetiform aphthous ulcers. These are ulcers that have never, ever been preceded by a vesicle, a little blister. They're just ulcers from the get-go, and you can see that we are looking at clusters of them that often will coalesce and sometimes form a larger area of ulceration on a variety of different locations here. Do patients get a warning when they're going to have an aphthous ulcer? Well, so-called prodromal symptoms in aphthous stomatitis are really not that common, not as compared to herpes simplex infections, okay? So they're uncommon in recurrent aphthous stomatitis, and what would they consist of? If they happen, the patient might complain of a burning sensation or some form of discomfort that is in the area that will give rise to an ulceration. And one thing that is very helpful in those rare patients who do get a prodromal symptom is that if you want to intervene and try to intercept the ulceration before it actually emerges, when you have a prodrome, you can actually apply therapy in that area where the ulceration would likely occur. Why do aphthous ulcers happen? They are very, very annoying. They are a common problem. They cause a lot of pain. And people always want to know, well, what the heck is this all about? Well, we don't really know why aphthous ulcers happen. The initiating stimulus is unclear to us. However, there are a number of theories out there. Perhaps this relates to some autoimmune type process. Perhaps it represents a hyperimmune state to some exogenous antigen. Maybe it's due to trauma. I think you could say any one of these theories is possible, but nothing has been proven about it. A whole slew of other possible causative factors have been exhaustively studied over the years. And pretty much all of the ones that are listed right here have basically been debunked. So some patients will also say that for them, they get an aphthous ulcer when they mildly traumatize their tissue. In other words, if they accidentally bite themselves, they don't even have to break the mucosa. But if they accidentally bite themselves, or if a utensil accidentally traumatizes the tissue, they say, you know, usually that's where I'm going to get my aphthous ulcer. But most patients will not say that trauma has anything to do with the advent of an aphthous ulcer. So here are a couple of examples of trauma-prone areas in the oral cavity where we see some aphthous ulcers. Well, one is on the buccal mucosa, and the other one is on the labial mucosa. These are typical trauma-prone sites. What do we know about aphthous stomatitis at this point? We do know that it appears to be an immune-mediated condition, at least in part. And we have recognized that local immune dysregulation, cell-mediated immune dysregulation, is very much a consistent finding. So just before the ulcer comes out and after the ulcer has been well established, we find a dominance of CD4 T lymphocytes, and while the ulcerative phase is active, we see a dominance of CD8 lymphocytes. There's also some question about perhaps the diminished mucosal barrier of this thinner, unkeratinized lining mucosa has the ability to allow for the perception of antigen. This is all theoretical. Mostly, this is a local immune dysregulation condition. So theoretically, what's happening is that you're getting a local T-cell mediated immune reaction that produces TNF-alpha, which leads to destruction of the surface epithelial cells via a cytotoxic T cell reaction. We also know that recurrent Apthtous stomatitis seems to be connected to some genetic factors. We know that if you have a positive family history of several close relatives with Apthtous stomatitis, it is likely that you're going to get Apthtous stomatitis. And your onset may be earlier, your episodes may be more frequent. This is not an absolute rule, but it certainly has been seen. And indeed, if both of your parents have a history of Apthtous stomatitis, it is likely that you're going to be much more predisposed to getting canker sores than someone out in the general population. It's also been known that there are certain histocompatibility locus antigen profiles of affected patients that seem to be common. Although not everybody gets studied, but these are some of the factors that have been looked into and been found in common with many individuals with Apthtous stomatitis. Now, when we're taking a history in a patient who comes for maybe diagnostic confirmation, but certainly for management of canker sores, there are certain things we also want to include as we're asking the patient some questions. We know that Apthtous, like ulcers, can be a component, or maybe even an oral manifestation, associated with several of the inflammatory bowel diseases. In particular, some patients with ulcerative colitis also get Apthtous ulcers. Some patients with celiac disease are prone to Apthtous ulcers. And we also know that among the various oral possible presentations in Crohn's disease, Apthtous ulcers do happen. So, just want to mention for a few minutes the kinds of things that we can encounter in Crohn's disease. As you know, Crohn's disease is a chronic granulomatous GI disease that actually affects the mouth to the anus. So it's a pan-GI condition. We know that it's immunologically mediated, and we also know that many patients will have their first episode indicative of Crohn's disease when they're in childhood or perhaps even in adolescence. And there's a variety of presenting symptoms, including abdominal cramping, diarrhea, blood in the stool, constipation. Very often patients who have had bleeding will develop anemia, they'll be fatigued, and they can also have oral lesions. But oral lesions do not necessarily occur in correlation with exacerbations of lower GI disease. They can be very much asynchronous. Sometimes oral lesions actually precede the onset of lower GI disease in Crohn's disease. This is very, very interesting, and it's something that we've discovered as we interview our patients. So what are some of the potential lesions that we can encounter in Crohn's disease? Lesions in the oral cavity. Well, as I mentioned before, patients with Crohn's disease sometimes get Apthtous-type ulcerations. They look very much like Apthtous ulcers, and they're painful. They often will have fissuring of the oral mucosa, and just as we would encounter in the lower GI on a colonoscopy, there are cobblestone-like thickenings in the oral mucosa, especially in the vestibules and in the buccal mucosa, that we encounter in Crohn's disease oral manifestations. These cobblestones, if you took a biopsy, would show very similar findings, granulomas, just like we'd see in the lower GI lesions. And there are a variety of other kinds of lesions, pustular lesions, and certainly swelling of the lips, so-called granulomatous cheilitis, is not an uncommon finding in Crohn's disease manifested around the oral cavity. So let's just look at a couple of examples of this. This was a little boy. He was probably somewhere around the age of 6 or 7. And as you can see, he's got enormously enlarged lips. They feel very doughy. And you can see at the commissures of the lips, at the corners, there is some crusting and maybe some fissuring and ulceration. And as we look at his lower labial mucosa, you can actually see some fine fissuring and thickening in that area. We can also see in the vestibule of the lower labial area of the oral cavity that there are some thickenings. There are some little folds of tissue that we can see in the upper left-hand photograph. And notice that the gingiva in the lower right-hand photograph, between those lower central incisors in the upper jaw, is quite thick. These are all lesions that if we were to take biopsies, they would show granulomatous change, very similar to what we'd see in the lower GI. So there are those folds that I was talking about in the lower labial vestibule. Now, Apthtous stomatitis is also a component of other diseases, and in particular, a major component of a relatively uncommon disease, but an important one, called Behçet syndrome, or we often call it Behçet's disease. It's unclear what the cause of Behçet's disease is. However, it is clearly an immunologic disease, and it may have some genetic component because HLA has been found to be a common factor in patients who get Behçet's disease. And I will tell you, as someone who sees patients, very often patients who get Apthtous stomatitis very frequently are often referred to me to rule out the possibility of Behçet's disease. So, Behçet's is basically a multi-system immune-mediated condition. And it boils down to a systemic vasculitis. There is an apparent genetic predisposition for this disease, and there are a whole host of possible triggers, all theoretical, that have been suggested as the underlying precipitant of Behçet's syndrome. But among the important key features of Behçet's disease, oral Apthtous ulcers are the bottom line. Oral Apthtous ulcers are absolutely a component of Behçet's disease. However, there are a whole host of others, and if we look at our list here, at least 2 of the other conditions beyond Apthtous stomatitis are important components of Behçet's disease. So here's a patient who we diagnosed with Behçet's disease, not just based on his oral ulcerations, although you can see that he's got several very prominent major Apthtous ulcers on the upper labial mucosa. He had several similar lesions distributed throughout the oral cavity, but he also had a history of genital ulcerations. So of course that puts him in the category of a consideration for Behçet's disease. Other things that we can see in Behçet's disease, aside from uveitis, we can also see that there is conjunctivitis in many patients, gangrenous skin lesions, oral ulcerations, erythema, and very often genital lesions as well. And one of the findings in Behçet's syndrome that is seen in about 80% of patients is a so-called positive pathergy test, where a little bit of sterile saline is injected under the skin, and within about 24 to 48 hours, a pustule forms at the area in someone with that kind of cutaneous hypersensitivity that is characteristic of Behçet's disease. So this is an example of a positive pathergy reaction in such a patient. There are a whole host of other systemic diseases that are associated with ulcers that have that Apthtous type appearance and distribution, and I've just listed them here. In HIV infection in particular, some of the Apthtous ulcers are tremendous, and they're very protracted, and they are very troublesome. But all of these conditions can have Aptthous-like ulcers. One point that I'd like to make, having talked about Apthtous stomatitis to you, is that, very important, most patients who get recurrent Aptthous ulcers simply have recurrent Aptthous ulcers. They don't have any other systemic condition. So that should be something to take home. So how do we confirm a diagnosis of Aptthous stomatitis? Well, there's really nothing that we can do in terms of laboratory procedures to really confirm our diagnosis. So it's very important to understand the clinical features and the historical features, because a clinical historical correlation is really the bottom line. Okay? Now, many patients will get very frequent episodes, sometimes very severe episodes. So we have to consider, as we take a history, some of these other underlying systemic influences and make sure that we can rule those out. Tissue biopsy, very limited diagnostic value, because by the time you get an Aptthous ulcer that you can actually see as an Aptthous ulcer, what you see under the microscope is going to look rather nonspecific. So again, clinical, historical correlation, very much the bottom line. What do we see under the microscope? Usually we don't even advocate taking a biopsy unless there's some real suspicion that it might be something else, but we see basically benign ulcers, very nonspecific. There's a lot of debris on the surface of the ulcer base. There's usually a lot of chronic inflammatory infiltrates, and maybe, in the deeper tissue, we might see some chronic inflammatory infiltrates around blood vessels. Maybe. How do we manage Aptthous stomatitis? In broad terms, we can do a number of things without getting into too much detail. If a patient knows what is consistently a trigger, we try to emphasize how important it would be to try and avoid those triggers. That can be pretty challenging. We can often give a patient something that will at least diminish their discomfort as the lesions run their course, especially if it's 1 or 2 lesions at a time. If we know that someone gets frequent outbreaks, there are some prophylactic measures that we can take involving the use of corticosteroid, usually topical agents, either in rinse form or in ointment form. And certainly immune modulation for actual outbreaks, active lesions, can involve the use of topical corticosteroids, or in some instances, we must use systemic corticosteroids for several weeks combined with topical corticosteroids and maintenance of that topical therapy indefinitely after the actual bout has resolved. And in very, very large individual aphthous ulcers that have been protracted, we often will advocate injecting around the lesion with some corticosteroid preparation. We often call that an intralesional injection, but it's really a peri-lesional injection, and that would be just for a major aphthous ulcer. Generally speaking, that kind of melts the lesion away within just a few days. Other management options that you will read about are very hit or miss. But other immune modulators have been tried, and there are a whole host of other agents that are listed here. Thalidomide in particular is a very, very iffy agent that should only be used in very extreme cases, but most of us are not licensed to use thalidomide, so I don't really talk about it as a practical agent to use. Is surgery indicated for aphthous stomatitis? Not really. Only if a lesion is very large and it's really, really resistant to treatment, then it can be excised, closed up with primary intention healing, and otherwise we don't really advocate using a surgical excision. So let's just sum up what we've learned about recurrent aphthous ulcers. We know that they are extremely common, and we see them in children all the way up to about middle age. We see outbreaks that are precipitated by factors that for every individual are unique. In some patients, they say, I don't know why I get them. In others, they say, whenever such and such happens, I know I'm going to get a mouthful of canker sores. Some patients will have recurrences very infrequently. Others will go through periods of time where they have very, very frequent episodes, sometimes even overlapping episodes. We know this is an immune-mediated condition, and one thing that's very important to take home is that it is not an infectious disease. So, other things that we need to remember. Aphthous ulcers, regardless of size, they are always quite painful. Patients will have a history of prior episodes and recurrences. Location, location, location. They are on unkeratinized, movable, lining mucosa, and they can also occur on the dorsal tongue. They typically run a 7 to 10 day course, and they may be associated with other conditions of a systemic nature. The important thing also to know is that if we understand that this is an immunologically mediated condition, we know that it can be managed, and it should be managed. So those are the important take-homes about aphthous stomatitis. Now, another condition that is also problematic, but thankfully not nearly as common, is erythema multiforme. Erythema multiforme is not really a disease per se, but more of a mucocutaneous immune reaction pattern. So it's a response to some kind of agent that has precipitated this immunologic response. The most common precipitants include medications, drugs, either prescribed medications, over-the-counter medications, or recreational drugs of all stripes. Alcohol in some patients can precipitate an attack of erythema multiforme, and we've also found that in some patients, a recent infection with either herpes simplex or with mycoplasma can precipitate erythema multiforme. Now, erythema multiforme is often described as a major outbreak or a minor outbreak. We don't usually break these things down too stringently, but if I had to define a minor outbreak or a minor type, It usually involves skin lesions with oral lesions or other mucous membrane lesions. In major type erythema multiforme, at least a couple of mucosal sites plus disseminated skin lesions are seen. Usually we see oral lesions and or lesions of the conjunctiva and or genitalia in a major erythema multiforme. What are the characteristics? Well, erythema multiforme is characterized by an explosively acute onset. Boom, within about 24 hours, the patient is absolutely miserable. And most of the time, with a good probing history, we can identify the precipitant of this episode. We also know that in many patients, they've come in with a history of having had something similar to this before. So obviously, if they are exposed to some kind of challenge and they're re-challenged, they are in danger, actually, or they are threatened by another episode of erythema multiforme. Their recurrences can vary in intensity, so sometimes we have a relatively mild presentation. Other times it may be much more widespread and a little bit more severe. And so we base our management of the problem on the extent of involvement. And we always look to identify, if at all possible, what may have precipitated the incident or the episode, because if we can eliminate or avoid that precipitant in the future, then the patient can avoid developing erythema multiforme once again. What kind of lesions do we encounter in erythema multiforme? Well, the skin lesions can be as various as just a wide spectrum. So I've listed here, you can have red lesions, you can have vesicles and bulli, in other words, tiny ulcers, tiny vesicles, or perhaps even larger blisters, ulcers, so-called target lesions, which I'll demonstrate for you in just a moment. They're very characteristic. Urticaria, which looks very much like hives, and purpura. This is another one of those perivascular inflammatory conditions, and so we can get some purplish lesions on the skin. So here are a couple of examples for you of so-called target lesions. In target lesions, we have a central area of erythema, sometimes a blister, and around that we see a slightly raised, somewhat swollen area of urtication surrounded by erythema. Sometimes that blister will rupture in the center and produce a small amount of crust or scab formation. So we see several examples of target lesions here on various different cutaneous surfaces. And here are a couple of examples of some other target lesions. In that upper right-hand corner, we see a young child with obvious conjunctivitis, and we see a target lesion in which the central portion, the vesicle or the bulla, the blister has ruptured, leaving a crusty surface, and around that the erythematous wheal. And of course, one of the key features here is the swelling and hemorrhagic, crusting appearance of the lips. We also can get lesions on the genitalia in erythema multiforme. Just some other examples of urticarial lesions and a widespread urticarial maculopapular rash in this young child. Other lesions can occur in erythema multiforme, as I mentioned before. The oral lesions will have redness, vesicles, bulli, meaning blisters, which rupture and produce ulcers, and the typical lesions that we encounter around the oral cavity would be those hemorrhagic, swollen, crusty-looking ulcerated lips, especially the vermilion border and sometimes the skin, and there can be purpuric lesions also on other mucous membranes in erythema multiforme. So just a couple of examples to demonstrate that the lips are involved here with those hemorrhagic lesions, and you can also get a sense that in the oral cavity there is considerable erythema, there are areas of ulceration there, it's very widespread. What we see is a very heavy coating, a white coating on the tongue, and we can see all of these lesions that are involving the lips and the mucosa, and the tongue coating is probably related to the fact that the patient is in so much pain that he can't really debride the filiform papillae on the dorsal tongue of the natural amount of debris that falls among them throughout the day because he's not able to eat or drink. So coated tongue is typically a sign of not being able to eat or drink. Just some other examples of those crusty hemorrhagic swollen lips. And in the lower picture, we can actually see not only that, but also intraoral mucosal lesions. Now, in terms of the pathogenesis of erythema multiforme, presumably some agent is introduced. And as I mentioned before, typically it's some kind of a drug. That's a good example. We have circulating immune complexes with that agent and the immune reactants that are binding to blood vessel walls. This liberates lytic enzymes, including TNF-alpha, which are toxic to the overlying epithelial cells or epidermal cells, and that results in this clinical spectrum of lesions that we see, this mucocutaneous reaction. So we can see either erythema or this widespread kind of necrotic change that is very much a very widespread problem. Under the microscope, if we're lucky, we can see certain features. If we have a lesion that is relatively new or young, we see lymphocytes that are migrating to basement membranes, and that would be around the blood vessels, as well as the epithelial tissue in the mucosa or the epidermis in the skin. We often will see good examples of perivascular inflammation, and we will often see the death of certain cells within either the epidermis or the mucosal epithelium, and eventually a necrotic destruction of the surface epithelium. We see ulceration and necrosis involving that surface tissue. And here are just some examples of that to demonstrate the lymphocytes homing up to the basement membrane or the interface between the epidermis and the underlying tissue. And we see as we watch this, we can see that there are certain cells within the epidermis that are dying. They're also infiltrated by lymphocytes. And in the lower photograph, we can see that there is now a separation and destruction below the epidermis. And eventually the epidermis will completely undergo necrosis. And here's a nice example showing the perivascular inflammatory infiltrates within the underlying dermis. Now, I mentioned before that we have found that recent infection with herpes simplex virus, whether it be primary herpes simplex infection or reactivated or recurrent herpes simplex infection, can sometimes precipitate an episode of erythema multiforme in some patients. In fact, in roughly 15% of cases, this follows a recent herpes simplex infection. So what's happening in erythema multiforme that occurs after a herpes simplex infection is that presumably the viral antigens are deposited in the skin and mucosa around vascular endothelial cells and among the keratinocytes, and that will induce a cell-mediated immune reaction. And so what happens is the lymphocytes, CD4 lymphocytes that are HSV specific, come into the area, they produce interferon gamma, that leads to keratinocyte lysis, and it recruits autoreactive T cells and results in epidermal and epithelial cells damage. So either the mucosa or the skin or both are affected in these cases. So how do we manage erythema multiforme? Well, first and foremost, we've got to try as hard as we can to identify the inciting agent, and that involves a probing history. Another thing that we want to do is, once we identify it, eliminate that precipitant if at all possible, educate the patient about avoiding it in the future. We certainly want to provide supportive care because if they have oral involvement, they're having difficulty eating and drinking, so we want to make sure at least they're hydrating. And of course, how we actually treat this is going to be dictated by how severe the outbreak actually is. So if we have a mild, local kind of outbreak, we probably want to use some topical immune modulation, maybe with some corticosteroid preparations. If it's very severe, we often will use both a systemic and topical approach to immune modulation over the course of maybe a week's time, and that usually gets the patient under control. But eliminating the precipitant is first and foremost. In terms of herpes simplex-related erythema multiforme, we certainly want to give them a systemic antiviral medication to try and address and prevent recurrences if they have these recurrences often. And in terms of some patients who get these lesions very frequently, or these outbreaks very frequently from herpes simplex infection, we often will put them on prophylactic antiviral medications for an extended period of time. So let's sum up what we know about erythema multiforme. It is not a disease per se, but rather a mucocutaneous immune reaction pattern. It is acute in its onset, and it can involve skin as well as oral mucosa, either or both. A whole spectrum of lesions can be involved. Patients will get recurrences if they are re-challenged by a particular precipitant, and of course in every patient the episodes will vary in their intensity and in terms of their distribution. So it's always important to search for the precipitant.